to go.
Okay, great. So I'll ask the first question to kind of just please introduce yourself and share what makes you interested in global health.
Sure. So my name is Srinivasan, and I've been interested in global health from a very young age. So my grandfather, I grew up in Chicago, but my grandfather was a surgeon out in India. And after a tsunami hit, I think in 2004, I was working with UNICEF back when I was in school. I didn't know anything about medicine at the time, but I remember just trying to build up huts and talk to children and patients who were affected by the tsunami, especially those who lost their family members. And I have this vivid memory of one child who was just detached from society. I was building up a playground and I would just see him off to the side with a blank expression. And that experience, even though I didn't know anything about medicine, it really wanted me to make a difference. It made me change my mind totally and want to pursue something in global health related. So that definitely got me interested from a young age. And then I think since I was working in India for the past several years as a radiologist, just experiencing the health disparities amongst the rural population and how terrible it is compared to the urban population, how they don't have access to healthcare, to diagnostic services. And even though a lot of the government provides free services, patient access is still a large concern because they live so far away from the nearest health posts and hospitals. So ultimately, I would like to make a difference, maybe at some point in my life, building centers that integrate the rural population more.
Oh, okay, that's incredible. Do you currently practice in the States, or do you like go back and forth?
So I'm working as a teleradiologist right now. I just moved back a few months ago, and so the nice thing about radiology is that we can get cases sent to our computer, and we can pretty much sit anywhere. So I get cases sent from UK and from India to my computer, and I report.
Wow. Okay, that's awesome. So yeah, we'll move on to the next question then. And that kind of ties into the first one. It's what has been one of your most impactful experiences working in global health?
Right. So recently, I would say we would last year we would make a lot of the company that I was working for in India called Metal. We would make trips to the rural parts of India. Even though it was primarily an urban hospital, they would let us go and perform ultrasound scans on patients in villages, and that completely changed my mind because I wasn't exposed to patients of that in that population and the type of just inequities that they were exposed to. I'll give an example. I remember performing a scan on one patient who was bedridden. He was a fisherman. And when I did his scan, I saw that both his kidneys had completely calcified, which means that they turned into rocks. And this is a sign of basically end-stage tuberculosis, where if the patient had gone to a hospital ahead of time, gotten treatment, this would have never happened. When I asked him why he never went, he gave several reasons. One was because he has to feed his family every day because of his job as a fisherman, and he's providing, I think, 3 kids at the time. So he could not take the chance to leave home for the 3 or 4 day journey it would take him to get to the nearest hospital just to get tuberculosis medicine and then come back because then his family would starve. The second reason he gave was that the government in India at the time was only providing medicine for 1 month. So he would have to go back and forth every month. And this 4 day journey was just not worth it for his life. Also, he just said that at the time he only had pulmonary symptoms and just having cough, sometimes blood in the cough, and a little bit of shortness of breath was not enough for him to decide to get treatment because he could still function and do his normal job with those symptoms. So that's a lot of that's kind of what I see a lot in tuberculosis patients, is that, especially the one in the rural populations, is that they just don't seek access to treatment until it gets too late. Not just with TB, also with cancers, with a lot of chronic diseases in India. So I think patient education is an issue because they just think that they can cope with it, and that, if they're able to perform their work and their careers, they don't have to seek medical attention. But then by the time they come to the hospitals in the urban areas, they present with all end stage findings. And it's so hard to treat patients who come with tuberculosis that is spread all over the body, or cancers that have progressed to an advanced stage, and so on.
Right. So you've noticed like a pattern within that population. That kind of feeds into the next question is, like, what are your experiences working with vulnerable? Like that kind of, there's like a disconnect in inability to go get treated, and also like the urgency, the sense of urgency that they feel because they're also kind of prioritizing, feeding their family and taking
Right.
care of work, things like that. Yeah.
Exactly. So I think you nailed it. I mean, the number one concern for a lot of the vulnerable population is being able to provide for their family. And
Mhm.
they think that as long as they can function normally, maybe having some weakness or cough, it doesn't really affect them to the point where they want to take off a week from work. The second interesting thing that I found that I didn't know before is how a lot of these diseases like tuberculosis and other infections, they're considered as taboos in India, TB
Mm.
especially, which I found the hard way, where I would perform a scan, and I was in like predominantly in the city area at the time, performing a scan on a patient. I saw he had tuberculosis because of, again, some complication that where TB had spread to his intestines. And when I told the patient, I just muttered the words TB, and you could just tell that he was in shock right away because he was worried. In India, sometimes confidentiality is a big issue because the patient's families will be sitting right outside the curtain where we're performing,
Okay.
so they'll hear what the doctor says also, even if we try to keep it between the patient. And so when I said TB, he became worried not because of his condition, but because he believed his family would kick him out of the home just because he had TB. So it's considered in some villages as like a religious curse or a disease in that sense that like God has put on you. And
I
so just
see.
the fear of being kicked out of home. And I think cultural competency is a really important thing in global health. And that's something that all like public health practitioners need to understand before they develop an intervention.
Yeah, I completely agree. I'm not pre-med myself, but I have a lot of pre-medical friends who hopefully, I mean, we see kind of this like medical school trend where
Mhm.
like cultural competency is not specifically stressed in the curriculum, but I
Mhm.
think, yeah, being able to understand, and I think having a global health background really will help in developing that cultural competency and being able to like connect with vulnerable populations in that way.
Definitely. And the
Yeah.
other thing that I think I mentioned before is just the poor infrastructure and primary care in the rural populations. There are health posts a lot of times, but there's no doctors or nurses or medicine in those health posts. It's usually just
Mm,
a village leader or somebody who is said to be the village nurse but doesn't really have a medical background, and they will take care of all the patients that come into the village. But because they don't really have prop out of it is either like spiritual medicine or it's not proper medicine that's being given. And for tuberculosis, you need to treat it with the adequate first and second line medication.
right.
So
When
that's
you go in, oh, sorry. When you go in, do you have like a team or is it like
yeah.
how do you?
So usually the camp will be there'll be almost 15 team members. So it'll
Mhm.
be like community health workers. It'll also be regular general practice physicians who will take every patient in the village and do a regular checkup, a history, a physical exam, and then provide whatever medicine is needed. Then our job as radiologists is we will take, it depends on how many patients are in the village, but typically we try to see every patient and just perform a routine ultrasound scan to check for any problems. But sometimes if it's a village of more than 2,000 people, we will go the day after the medical doctors go. So if the medical doctors suspect any positive findings, then we'll perform ultrasounds on those patients for free.
I
And
see.
it's a pretty large team. There's lots of nurses as well that come along and they perform blood tests and everything.
Okay. And how often are you going and like how long are you there for?
So because this is all free work, we usually would do it about once or twice a month, and they would be
Oh,
there
okay.
like a Saturday Sunday trip.
Got it.
Mhm.
Okay.
I would like for it to be incorporated more, but a lot of times the private organizations and hospitals in India, they don't make a profit from these type of trips. So that's something that NGOs and hospitals do need to incorporate more.
Right. Yeah, great. We just have a few more questions. So the next one is, have you drawn, this is kind of a big grand question, but what conclusions have you drawn from your experiences working in global health or even your experiences as a doctor in general?
I think two of the main things that I've learned is that patients just lack knowledge of a lot of not even just diseases and how to prevent diseases, but also they lack knowledge of what services are available to them. For example, in India, a lot of medicine is free for patients. There's a lot of government hospitals that everything is provided free of cost, but patients don't know this. They believe that if they go there, they're going to be charged with tons of different things. So they just end up not going. So I think education of patients, community involvement is extremely important. Recently, with Fund for Global Health, we had an interview with the CEO of an NGO in India called Operation Asha, which
Mm.
does amazing work in providing the last mile approach to patient. They basically go into villages door by door, and they educate and train community health workers who are disadvantaged youth in the villages. And then they train them to, again, go door by door and basically provide surveys and on everybody in the village, checking for tuberculosis symptoms. And if they find positive cases, then they send a team in to diagnose and treat these patients. And they ensure compliance by having like an e-compliance software within tablets where they can check if patients are tracking their doses properly and everything. So it's a great, I think that's what's really needed in global health, is a way to get physicians or nurses to patients rather than making patients come to hospitals that are very far away. So that
Right.
last mile approach is very, very important.
Yeah.
Mhm.
Oh, okay. That's great. And then lastly, especially since you also work with the Fund for Global Health, I would assume that advocacy is kind of like part of your wheelhouse. Um, but within the field of global health, how can you be best supported, or how can the Fund for Global Health contribute to your sense of advocacy?
Well, I'll give an example. So about a few weeks ago, we actually went with a team of Fund for Global Health members to DC to speak
Mhm.
with our senators and representatives. And so for me, my senator is Senator Durbin, and we got to meet with his staffer in charge of global health policy. And I think it was great just explaining to staffers or representatives the importance, based on your experiences in the field, and just the importance of providing funding for maybe not even to governments, but to NGOs that perform the important work. And so what I realized from that meeting was that a lot of times they don't, like the politicians or senators, they don't have a clear understanding of what actually goes on in the field. So just explaining to them really changes their mind and makes them want to contribute more. For example, like Senator Durbin's staffer, she was amazed that tuberculosis can actually spread outside of the lungs, which is what I saw most of the time. I mean, a lot of people do kind of consider it just as a lung disorder and causes cough, but it can go anywhere in the body. And when I explained that to her, I mean, she was surprised. And that's like a major funding element of global health. So I think just explaining to politicians and advocacy work and seeing how terrible some of these diseases are if patients don't get treatment is really important.
Yeah, I agree. And how did you get involved in this like advocacy work?
So I'm doing an MPH through George Washington right now.
Oh, very cool.
And because through the global health track, and
Mhm.
through that I found Fund for Global Health. I think they had a system where they were looking for people for volunteer work in global health, and I found Fund for Global Health through that, and it's been amazing so far.
That's great. I'm an undergraduate at the University of Washington,
Okay,
and I study public health, global health. So
great.
hopefully I'll be in your position one day getting my MPH.
Mm-hmm.
George Washington's a great school, so I would not it would be
That's
wonderful to
amazing.
go there. But
Mhm.
that's great. Uh, that's all the questions that I have for you. Do you have any questions for me or about this interview? About
I know. I just think this is a great initiative, just to get, because all physicians come from totally different backgrounds. So just
right.
like having people explain their experiences and everything is really good.
Yeah.
Mhm.
Well, yeah, thank you so much for your time. I'll let you go.